A 28-year-old woman ate a very delicious seafood in a luxury restaurant. This is what happened to her organs. Linda and her family visited a luxury hospital's dining facility in San Francisco for lunch. Among the dishes ordered was a fish delicacy, which Linda consumed primarily. The dish was presented as a gourmet specialty, and Linda, a seafood enthusiast, was particularly excited to try it. The rest of the family opted for different menu items, making Linda the primary consumer of the fish dish. The restaurant prided itself on its exotic and high-quality seafood offerings, and the fish dish was one of its signature items. Approximately 30 minutes after finishing her meal, Linda began to experience an unusual tingling sensation around her lips and tongue. This sensation quickly escalated to numbness, causing her to become increasingly concerned. Within the next hour, her condition worsened as she developed nausea and a mild yet persistent abdominal discomfort, which made her feel uneasy and uncomfortable. As time passed, Linda's symptoms continued to intensify. Over the following 2 hours, she noticed a significant decline in her physical strength, becoming weak and unsteady on her feet. She found it increasingly difficult to maintain her balance, and walking became challenging. The weakness progressed to her arms, and she experienced difficulty performing simple tasks requiring manual dexterity. Linda's family, alarmed by the rapid deterioration of her condition, brought her to the emergency department of a nearby hospital. Upon arrival, Linda was conscious but clearly in distress. She was able to communicate her symptoms, reporting a sensation of difficulty breathing that added to her growing anxiety. The weakness in her limbs had become more pronounced, making it challenging for her to move or even hold objects. The medical staff quickly assessed her vital signs, noting a slightly elevated heart rate, which could be a response to her distress or an indication of her body's struggle to cope with the toxin. Her blood pressure remained within normal limits, offering a small reassurance amidst the concerning symptoms. A detailed neurological examination revealed a significant reduction in muscle strength in both her arms and legs. Her reflexes were also found to be diminished, a classic sign of neurological impairment. Despite these physical symptoms, Linda's mental status remained intact. She was alert and oriented, able to answer questions and follow instructions, which was a crucial factor in her ability to provide a history of her symptoms and recent activities. The emergency department team recognized the seriousness of Linda's condition and the potential for rapid progression to respiratory failure. They initiated immediate supportive measures and prepared for further diagnostic tests to confirm the suspected diagnosis of tetrodotoxin poisoning and to guide her treatment plan. Upon Linda's presentation to the emergency department, the doctors were immediately concerned about the possibility of tetrodotoxin poisoning due to her recent consumption of fish and the rapid onset of her neurological symptoms. Tetrodotoxin is a potent neurotoxin known to be present in certain species of pufferfish and can lead to severe, potentially fatal poisoning if ingested. The doctors considered Linda's clinical presentation in the context of her dietary history. The distinct progression of symptoms, starting with perioral numbness and tingling, followed by gastrointestinal disturbances, and progressing to muscle weakness and paralysis, is characteristic of tetrodotoxin poisoning. This clinical pattern and her recent fish consumption raised the suspicion of this diagnosis. In addition to tetrodotoxin poisoning, the doctors considered other potential causes of Linda's symptoms to ensure a comprehensive evaluation. Ciguatera poisoning caused by consuming fish contaminated with ciguatoxin. This condition can present with similar neurological and gastrointestinal symptoms. However, the rapid onset of symptoms and the specific type of fish consumed led the doctors to favor tetrodotoxin poisoning. Various types of shellfish poisoning, for example paralytic neurotoxic, could present with similar symptoms, but the absence of shellfish consumption in Linda's history made this less likely. Conditions such as Guillain-Barré syndrome or myasthenia gravis could cause progressive muscle weakness, but the acute onset following fish consumption and the specific pattern of symptoms made these less likely. The doctors considered other potential toxins that could cause similar symptoms, but the specific context of fish consumption and the symptom pattern directed them toward tetrodotoxin. The doctors decided on tetrodotoxin poisoning by carefully analyzing Linda's symptoms, the timing of their onset, and her recent dietary history. The lack of a definitive laboratory test for tetrodotoxin meant the diagnosis had to be made clinically. The rapid progression of symptoms, starting with perioral numbness and leading to muscle weakness, is a hallmark of tetrodotoxin poisoning and help to differentiate it from other potential causes. Given the potential for respiratory failure and the severity of the condition, the doctors prioritize supportive care and close monitoring while keeping a high index of suspicion for tetrodotoxin poisoning. The diagnosis was ultimately clinical, made by synthesizing the available information and ruling out other potential causes based on the clinical presentation and history. Treatment: Linda was immediately placed on supplemental oxygen and continuous cardiac monitoring due to the risk of respiratory failure and cardiac dysrhythmias. Activated charcoal: although it was beyond the ideal window for administration, activated charcoal was given to reduce any remaining toxin absorption. Linda's respiratory function was closely monitored. She was intubated and placed on mechanical ventilation when her respiratory efforts significantly declined, as indicated by a drop in forced vital capacity, FVC, and a negative inspiratory force, NIF. Intravenous fluids were administered to maintain hydration and blood pressure. Antiemetics were given for nausea, and Linda was monitored for any signs of cardiac dysrhythmias, with a plan to use antiarrhythmics if needed. Linda was admitted to the intensive care unit, ICU, for close monitoring due to the potential for rapid deterioration. Maintaining adequate ventilation was challenging due to the progressive paralysis. Regular assessments of respiratory function and preparedness for immediate intubation were crucial. The lack of a specific antidote for tetrodotoxin meant that treatment was primarily supportive, focusing on managing symptoms and preventing complications. After 48 hours in the ICU, Linda's condition gradually improved. Her respiratory function stabilized, allowing for extubation and eventual discontinuation of mechanical ventilation. Her muscle strength improved over the next few days, and she could walk with assistance. She was discharged from the hospital after a week, with a referral to physical therapy for ongoing rehabilitation. This case highlights the importance of prompt recognition and management of tetrodotoxin poisoning, the critical role of supportive care, and the challenges associated with treating toxin-induced paralysis in Linda's case. Takeaway: the pufferfish, considered a delicacy in multiple countries, contains tetrodotoxin, which causes sodium channel blockade and can lead to muscle paralysis, respiratory failure, and death. Pufferfish are members of the Tetraodontidae family, with almost 200 species known. Most pufferfish contain tetrodotoxin, a dangerous marine toxin up to 1,200 times more toxic to humans than cyanide. Tetrodotoxin is heat-stable, odorless, and tasteless. It exerts its dangerous effects by binding to voltage-gated sodium channels in the nerve and muscle tissue, blocking the flow of sodium ions across this channel and preventing the generation and propagation of the action potential. This results in paralysis, which can lead to respiratory failure and death. Intoxication from ingesting affected species was previously isolated to countries with historically higher pufferfish consumption: Japan, China, Korea, and Taiwan. Pufferfish, or fugu, is a delicacy, and perioral numbness is a well-known effect. There is an increasing frequency of human poisonings from ingestion of tetrodotoxin-containing pufferfish in less traditional areas, including multiple countries in the Mediterranean as well as the US, Australia, New Zealand, and Spain. It is thought that the spread of toxicity from pufferfish worldwide may be secondary to increasing global water temperatures. Most cases will present within 5 to 30 minutes of ingestion. However, onset of symptoms as late as 20 hours after ingestion is reported. Gastrointestinal symptoms of tetrodotoxin include nausea or vomiting, hyperemesis, abdominal pain, gastrointestinal motility disorders, hematemesis, and diarrhea. Cardiac effects of tetrodotoxin include dysrhythmias, AV nodal blockade, bundle branch blocks, hypotension, and cardiac arrest. Finally, it can cause neurological effects including paresthesia, perioral numbness, slurred speech, progressive paralysis, aphonia, and coma. Tetrodotoxin does not affect mental status. Poisoning may lead to a locked-in-like syndrome with fixed and dilated pupils even while conscious. Paralysis can ultimately lead to respiratory failure and death. Full recovery is possible within 2 to 3 days with prompt and appropriate management. In managing acute tetrodotoxin toxicity, consider activated charcoal for patients presenting within 60 minutes of ingestion if the patient's airway is not an imminent threat or has been secured. Respiratory support with oxygen as needed. Have a low threshold for intubation. Serial VBGs, ABGs, chest x-rays, end-tidal CO2 monitoring, and serial measurements of FVC, forced vital capacity, or NIF, negative inspiratory force, may help detect impending respiratory failure. Supportive care with antiemetics, IV fluids, vasopressors, antiarrhythmics, or inotropes is needed. Hemodialysis may expedite clearance and has been used in case reports. Acetylcholinesterase inhibitors such as neostigmine have been used with varying success in human cases. Anti-serum, monoclonal antibodies, and polyclonal antibodies against tetrodotoxin have been tested successfully in animal studies but are not approved for human use. Wrap up. While symptoms typically appear within 30 minutes, patients with suspected poisoning who show no symptoms should be monitored for a full day, as there have been delayed symptom onset. The cornerstone of management lies in vigilant monitoring and providing supportive care. It's crucial to closely watch for any signs of respiratory distress and intervene promptly when necessary. If there are early indicators of respiratory compromise, it's advisable to consider intubation proactively to prevent further deterioration. Although the focus is currently on supportive care, ongoing research may lead to more targeted treatments. Thanks for watching Medical Toxicology. Take care.